Okay. Um, yeah. God bless us. Hello, everybody. It's a great pleasure to be here with you all the OHI audience, also in the Spanish language, English language, and also for Russian speakers. So, my name is Gustavo Passarelli Petris. I'm from Brazil. I'm an implantologist, but for the past 5 years, all my work is concentrated to restorative dentistry, especially on biomimetic restorative dentistry, guided by Mr. Dave Dalleman, who is my mentor, Mr. Simone Deliperi, and I'm very happy and proud to spread all the knowledge and all the work that I'm producing on this past 14 years of my profession to deliver you people that watching this presentation, watching this class in this course, the best of dentistry, the best of restorative dentistry. Not the best looking dentistry, but the solid restorative dentistry, long lasting dentistry. That's the meaning of biomimetic restorative dentistry. Just for start, I'm 38 years old. I graduated in Brazil on Paraná University called Unipar, where I was teacher also. I was teacher of dental materials, of restorative dentistry, of prosthetic dentistry. But nowadays, my work on lecturing is more concentrate on immersion course, also in Brazil and also abroad. So I'm very glad to be here and to put everything together, my knowledge and my clinic, to deliver you the best of that I believe of dentistry. That couldn't be possible without photography, without magnification. So if there is two things that I could start the presentation that changed my life, that changed my dentistry, that's a game changing, is to catalog everything that you do. That's just possible without a good photography. The photography is the teacher, the lecturer that don't lie to you. Whenever you take a picture and your work isn't so good or it's good enough, you just by yourself take this knowledge. You will look at your picture and just know if your work is great or not. That push myself to do better. That struggle me each work that I do to do the best that I could deliver. So all this presentation doesn't have any relevant financial relationship with any commercial interest, and all my presentation is done by me. All the pictures are mine, and there is no reference to any investigation or for any off-label use of product. So the presentation of today is about direct composite restoration, a biomimetic approach for strictly compromised tooth. We will pass step by step of not so big problem to bigger problem, and you will see by each case that I will present for you little tips that will help you to achieve your better dentistry in the manner that you could do in your office with the materials that you have in your office. Biomimetic restorative dentistry isn't a material dependent dentistry. It's depends just of you. On this last 5 years, I'm very proud to be part of teaching team. This teaching team is called Operato. It's compounded by 4 teachers: me, José Carlos Dornelas, Marcelo Goulart, and Fábio Salomão. We are working all the Brazil, providing immersion courses about restorative dentistry, also for anterior restoration and also for posterior restoration. And I'm very happy to be part of this team because we are 4 young teachers, not so young, but 4 young teachers providing courses, and we already have more than 2,000 attendees, and that's a quite big number that we could say that we touch in some way in those dentists' life, in those dentist clinics, and start the game changing for them too. So I will present you a short video of one of our courses that we started this courses, and I developed this course that called Mimetics in 2017. At this time, I really didn't have all the knowledge that I had today about my biomimetic restorative dentistry, but I already knew the meaning of restorative of adhesive dentistry. So I'll show you in a short video a little bit of our work on this course that is called Mimetics. Oh, sorry, I just pressed the wrong button. I'll start it again. That's operato. That's the meaning of all we enjoy each minute that we are teaching on. So let's start today. What do you call success? Is that a amalgam, Surviving for 25 years is success. Is that right? When you when a patient come to your office and say, "Hey, I have this restoration and it has 25 years old." The another dentist that I went said me, "Do not touch in this restoration. This is surviving for 25 years. Look how great it is." And I say to you, the great thing of it is the tooth that is surviving under this metallic thing that is harder than the tooth, that is an adhesive dentistry, and that could take your tooth or take the patient tooth to death. That's the death, you know, caries and the restoration, deflection on all this tissue, and the real thing about metallic restoration is that you have to indicate the change, all of it. Doesn't matter if it's a tiny restoration or if it's a big restoration. But if you have a big restoration, you have to have the knowledge to restore the stuff. You have to have all the materials, all the tools to achieve the best result. Doesn't matter if you go to direct or indirect or semi-direct, whatever. You have to have the knowledge, you have to have the materials, you have to have the tools to achieve the best restoration, to achieve the best result for the patients, to achieve the best and the long-lasting restoration for these patients. That's a adhesive dentistry. That's a adhesive restorative material. That's a composite restoration. All that I'm doing in this past 14 years, 15 years is restore big restoration of like this, just using composite with a high success rate. I could say you that I could restore a tooth like that and doesn't take so long to do that, to perform the restoration, but this restoration will last for several years. And the best thing of composite is the chance that you have to redo it or to repair it. So the best material to restore it is a composite. But why, when we look in a restoration like this, of 15 years of restoration, sorry, this is in Portuguese right here, but why, when we look in a restoration of this, like 15 years old restoration, and with a little bit staining, with a bubble, we call it of insuccess. Why we do that? Why do we indicate a change of restoration just because it has a little bit of staining? Understand one thing. When you perform a restoration, in the very beginning of the life of the restoration, it will have a good looking face, okay? Just as you, just as me. When I born 38 years ago, I was a very cute baby. But look at me now. I'm old, you know? The age will act to me, and the age will act to this restoration. And if you have a 15 years old restoration, 20 years old restoration, 30 years old restoration, you will see a lot of staining. You will see a lot of bubble of pigmentation and whatever. But a adhesive dentistry makes your tooth stay together, stay connected, even if it has a little bit of staining. So the best thing to understand about composite is that the age will act over it, and it will get old, and it will get stained, and it will lose the shape, but the tooth will still reconnected. We have some papers. We have a special papers, actually two papers from a friend of mine. I could say that the teacher called Paulo Rodolfo in the operative dentistry, two papers of 22 years and 33 years of follow-up of those restorative of those composite restoration on posterior tooth. On the 22 years follow-up of this restoration, he shows us that 76% of this restoration is still intact. For sure, 22 years old, you see a old restoration with a little bit of staining, with some bubbles, and maybe with no shape, maybe with some wear, but still reconnected. And 76% of satisfactory restoration is a good number. It's a quite high number, and we could indicate this material. And remember with me, 33 years ago, what does we have to restore? The very first composite, the very first adhesive indenting that doesn't even perform a good adhesive layer to dentin, but still reconnecting the tooth. 76% is a quite high number. In 33 years of follow-up of those posterior restoration, at not a short number, that's a 75,000 restoration. 33 years of follow-up, 6% of surviving rate is a very big number. Whenever Paul has a chance to repair, to repolish it, the number just get up to 70%. That's a quite high number. That's a number that we want to go. But why don't we understand how to prevent or how to maintain those restoration in the mouth? That could be translated by this paper that I'll show you after. For sure, we want to get this kind of result. We want to get a good-looking restoration, well adapted with no staining. We could achieve this kind of result, but how to do that and what we have to understand to do restorations like that? For sure, we have to practice a lot to achieve this kind of result, but we have to understand why the composite fails, or why the composite are working on. That paper of Jack Ferricane. Jack Ferricane is from United States. He's an engineer. He doesn't even is a dentist, but he's the he produced the best papers that I ever read nowadays about interfaces, about polymer materials, and about adhesive behavior of hybrid layer together to composite. And he wrote this paper showing us this kind of result, this kind of lifetime, this kind of surviving rate. That's a systematic review with meta-analysis, but this paper has a very good question for the title. The title says, is the polymerization stress mainfully, or what the problem with polymerization stress? What does it cause? And when we see this kind of surviving rate, I really don't believe that any of you or me, we want to perform a restoration and say to the patient, hey, look, this restoration will last for maybe 6, maybe 7 years. Okay, then we will have to change. We don't want this kind of result. We want to have the result of Paulo Rodolfo, for example, like 22, 33 years of lasting of restoration. We want a long-lasting restoration. But why Paulo has this kind of surviving rate, like 22, 33 years, and why Ferricane have this kind of numbers, 6 to 7 years? First of all, it's about our interpretation when we take a look at restoration. Second thing is because all the patients that were with Paulo 22 or 33 years ago is still with him nowadays. And he is the only one dentist that is following this restoration, and he knows that the age will act over this restoration, causing some wear, causing some staining. But knowing that this restoration will get old and this will get a little bit of staining, or maybe it will fracture and I could repair or repolish, make this restoration survive a little bit more, because he knows that everything under this restoration is fine, is healthy. And the word here for maintaining restoration or maintaining structure is maintaining health. And the objective of doing restoration is maintain health of the patients, maintain health of all teeth in this mouth of this patient. But this 6 or 7 years in this systematic review is showed to us, because nowadays patients doesn't have, not generalizing, but the most part of patients doesn't have the compromise to stay with the same dentist. And all the dentists, I could say here by Brazil, my feeling, when a dentist take a patient for the very first visit, maybe 70% of dentists indicated change of restoration just cause it has a little bit of staining, or maybe a little bit of a bubble, or maybe a little fracture that could be repaired, but they indicate a change of restoration. And maybe those restoration was surviving for 20 years. Then we just take the bars on, take it off, and cut the lifetime in the middle. And imagine it in a whole universe of dentists that we have in Brazil. In Brazil, we have maybe 200,000 of dentists. It's quite big numbers, and getting higher doesn't stop this chain. But we have to understand that the meaning of this paper is understand that your restoration will get old, understand that your restoration will get a little bit of staining and that you could repair, and don't take this composite as you take amalgam. Look of those second sentence when say the composite failure due to caries is typically higher for composite than from amalgam. It's related to the third sentence that says that both composite or amalgam is reduced, lifetime is reduced when patient has high carie risk status. The first thing when we get a patient with high carie risk status is to treat this patient and teach him how to brush, how to floss, how to maintain health. And the fourth thing is understand that composite is an amalgam. And here, that's an important thing. Composite and amalgam have the same similar service life as a dental. The composite may have similar service life as dental amalgam. When I see this sentence, it makes me understand why those restoration doesn't survive longer. Because if we take, for example, 15 minutes and we can take more than that to perform an amalgam restoration. But if we, for a class 1, for example, of composite, we perform a restoration in 15 minutes, what's going to pass? Maybe we just step over in some step of a restorative protocol just to make it quicker, and my restoration wouldn't survive longer because I just took a little time to take care with the prepare, to take care with all the adhesive protocols, and so on. So when I will perform a composite, I just have to put in my mind that first of all, it isn't a composite. It takes time to perform a composite restoration. It takes time to prepare. It takes time to do the bevel on the cavo superficial angle. It takes time to clean the cavity. It takes time to do all the adhesive protocol. It takes time to put the composite on the tooth, to layer it, to finish it. And for me, to perform a class 1, maybe it take not less than 1 hour for a little class 1 restoration. But we see a lot of dentists performing restoration like this sentence, like or similar, like amalgam taking very short time, and the result is a not last long restoration. And the Cochrane library show us a review, a ratio of surviving comparing amalgam to composite, showing that for each 2 restoration of composite that fails, 1 amalgam fails. Why that? Because When the amalgam fail, what actually whose fail is the tooth. And I heard this sentence when I was in the graduation from my teachers, and they say, "Look, the amalgam is so good that it's still there, but the tooth just fractured." That isn't right. Something is wrong. I don't want to see a restoration is still there and tooth failing. I want to see my restoration fail. I want to see my restoration failing, and maybe I could do a little bit of repair, or maybe I could change this restoration and perform it better. The thing is, if we reconnect the tooth with adhesive dentistry, with biomimetic restorative dentistry, we could assume or presume that this tooth will last longer, not those 6 to 7 years in this systematic review, but we want to see same results as Paulo has, 22, 33 years, or maybe more. Who knows? I want to be alive to see all the success and to see another papers of the researchers that coming up from today, and maybe we'll have some new results on the next maybe 10 to 15 years. So, what is a direct restoration? Direct restoration is a restoration that are bonded directly to the cavity. But what the most difficult part of performing a direct restoration? Why those restoration fail? Remember the paper of Jack Ferricane that asking us, is the polymerization stress mainfully? For sure, that's really mainfully. But how to control or how to prevent the C factor? The first thing to prevent C factor, and those words came from Mr. Pascal Maillet, control the V factor. How do you control the volume factor? Knowing how to put each layer of composite. Controlling the amount and the position in the order in a protocol appropriate to perform the best, not just good looking restoration, but the best adhesive dentistry that will put all the structures of the tooth together again. The best way to prevent the C factor or to control the C factor is performing a semi-direct or indirect or semi-indirect, I don't know. Here in Brazil, we have a problem because when we say semi-direct, it's quite confusing to understand what is a semi or what is a indirect or what is semi-indirect now. That was described by Pascal Maillet. I have my proposal for restorative procedures. I know that all the literature showed us this kind of classification, like direct, semi-direct, semi-indirect, indirect restoration. But for me, I really believe that we have just four kind of procedures, four kind of restorative procedures: direct restorations, semi-direct restoration that are performed over the tooth, indirect restoration that are all the restoration that are performed, doesn't matter if it's performed over a flexible model, if it's performed over Gibson model, if it's printed or if it's milled. If it's performed over the mouth in another model, it's for me it's indirect restoration, and also the direct indirect that are proposed for Newton fall. But here we have the sentence saying, the first sentence saying that the use of semi-direct restoration described on the biosubstitution in the biosubstitution described by Spreafico and Didier Dietrich, showing that this is the best way to prevent DC factor control. In this paper, that's a funny thing. In this paper was also, that wasn't described in the paper, but Didier and Spreafico already performed IDS that came up on 2005. They already performed deep margin elevation, deep margin relocation. In those time, 97, they substitute the dentin with composite, and they substitute the enamel with feldspatic veneer or feldspatic inlay onlay or overlay or whatever, with a semi-direct restoration. But I could say that it could be performed with composite also. You could use a semi-direct composite restoration to do the indirect animal replacement, and that's the best way to control, to prevent the C factor over a cavity. Use the stress-reduced direct composite that was described by Delipere and Bardwell. It's also another way to prevent the C factor. That's use strategic replace of composite in strategic places and compounding with fiber, with polyethylene fibers, and by this way all the authors show us that we could prevent or we could reduce the stress that are actually produced by a direct restoration. Using the IDS or using the resin coating is also related to the first sentence, because doing this, what we actually perform is an enhancing of the hybrid layer, and enhancing the hybrid layer, we have some higher result of adhesive layer performance, and all the stress that are produced by the composite isn't in a great rate or in a great sorry, my connection is just closing here. I'll start again. Okay, using the IDS or using the resin coating is related sentence to the first sentence, because when we enhance the hybrid layer, we perform a better result and higher result of adhesive compounding, and by this way the stress that are produced by the composite doesn't act to the hybrid layer actually, because the hybrid layer, when has the high value of adhesive values, prevent the stress that are produced by the composite. That's the way to decouple also. And in the sentence 5, 6, and 7, we have all the sentences that show us that we could prevent the C factor by doing decouple. Decouple with time, decouple with fiber, or decouple bonding first to animal, then to the dentin. When the first time that Mr. Dave Dalleman called me, I could remember he asked me, Gustavo, for how long are you performing biomimetic restorative dentistry? And I asked him, am I performing? That was funny because all the procedures that I were performing, I learned on my graduation, for sure. I was getting better. I wasn't the same dentist like 15 years ago. My work wasn't the same 15 years ago. I'm doing better, okay, for sure. But I didn't knew that actually I was performing biomimetic restorative dentistry. Nowadays, I know all the science about that, but I still doing quite the same with some different steps, and that's what I'm going to show you in the next cases. Look at this. What does we have? First of all, deep cavity, a very deep cavity and very close to the pulp. What's the meaning of biomimetic restorative dentistry? The meaning is keep the pulp alive. That's the meaning. Keep the pulp alive. How could I do that? Preventing on the preparation of the tooth. Preventing by selective remove of caries in the tooth. But for start the preparation and doing selective remove of all the caries, we have to have a alive tooth. So the first thing when we will restore a tooth like that is to do the test of this pulp. We have to do the cold test, we have to do the heat test, and just check if this pulp is alive for perform the selective removal of this carie, maintaining all this deep carie that's near to the pulp and bonding afterwards or perform this restoration afterwards. So how to start a restoration, a big, a deep restoration like that? What is the first step? The first step for performing a restoration like that is to doing dam isolation, is to doing absolute rubber dam isolation. Always I work under isolation. Why that? Because I read a paper that says that isn't important, but when you check this paper and you'll see who is the one that's saying or showing us that the isolation is an important or relevant item for composite restoration, we'll see, and taking a deep look, we'll see that this dentist is Nick Obden, and Nick Obden work with 4 hands, 2 dents as a system with leaf sucker and all the control of humidity. And it couldn't be performed by me because most of my time I work alone or maybe with more 1-2 hands, and that's impossible for me to perform a bonded restoration without rubber dam isolation. But just using rubber dam isn't enough. You have to have a deep isolation. You have to have a very nice and soft adaptation of this rubber dam over the tooth or contouring the tooth to prevent bleeding, to prevent fluids, to control the humidity during the restoration. First thing, remove the old restoration and take a direct look to this cavity. Look at that. What we have? We have different dips cavities. We have a deeper area on this distal side and a not so deep from the cavo superficial angle in more this mesial part. How to prepare that and prevent the pulp exposure? I use this paper as reference, this paper that was written by Dave Dalleman and Pascal Magne, and they describe the peripheral seal zone. How important is the zone? Why do we have to take so much care doing this preparation or doing this first step of preparation? Doing the preparation, knowing the peripheral seal zone will prevent, it will not just prevent the pulp exposure, but it will help you to achieve the best tissue to bond over it. All this area in the first 3 millimeters from the contact point of the next tooth is the best area to bond composite over it. Why that? Because this area has the best tissues with the high values of flexural strand, like GAD. The animal dentin junction, animal dentin junction is the best tissue to bond over it. Why that? Because it has the high values of flexural strands. Those high values of flexural strands, like 70, maybe 80 megapascal, show us that we could perform the best adhesive protocols to this tissue, but it can't have caries lasting in this area. So, knowing how to prepare on the peripheral seal zone is knowing that we have to prevent the pulpal exposure, but we have to prepare and clean well this peripheral area due to achieve the best bonded surface over this tooth or over this cavity. After that, we will see, and taking a closer look to a tooth, we will see like this peripheral seal zone, like those first 3 millimeters, are compounded by 1 to 2 millimeters, or 1 to 1.5 millimeters of enamel, 0.25 millimeters of dentin enamel junction, and 1 to 2 millimeters of peripheral dentin. Working like that will prevent pulpal exposure and will also prevent to have a carry in this area, and you achieve the best dentin to bonding over it. And there is no much rules to work in the peripheral seal zone, but you could use just a probe to do that. You could use dye, the carrier detecting dye, to remove and to clean the surface. You could work with air abrasion. You could work with pores. You could work with excavator. But you have to know that you have to achieve the best tissue before bonding to this tissue again. The next step actually is to construct or to simplify this restoration. That's what I learned in the graduation. But remember the sentences for controlling the C factor. And there is one sentence that says, bond first to enamel. And that's what I want to do. I want to bond first over to enamel, preventing what? Preventing all the stress that it could be created by the composite over the deep dentin. The deep dentin is the deepest area of this cavity, and not just the last result of bond strengths, but also the high concentration of C factor during the area that I will bond to. One manner to prevent or to achieve best results of bonding surfaces on those deepest areas is working with fibers. As influence of the second sentence that I showed you before, by stress reduction, direct restoration, that's a blended of technique. But I'm using this polyethylene fiber that will cause the stress reduction in the deepest area of this tooth that's actually close to the pulp. I just have to measure this area, cut this piece of fiber, and after perform the adhesive application and curing this adhesive, I could embed this little piece of polymer of polyethylene fiber to a pure adhesive with no filling. That's the indication of manufacture. Cut the fiber, embed it on a pure adhesive, then place it in the area that will bond. And I placed it over the area that has the last result of bond strands and the area that has the higher concentration of C factor in this cavity. So I cut this piece of polymer of polyethylene, embed it on this clear FUSA bond just in the adhesive for 3 to 5 minutes, and after cured the adhesive that I put in the tooth, I just place this fiber over this area. As you could see here, this fiber is put on this place to prevent the composite that will cause shrinkage, to prevent this composite not to act over the hybrid layer, but to cause all the stress just over the fiber. So that's the why we use fibers on those deepest areas in this cavity. We don't have to use fiber to reconstruct or to reinforce the composite actually, but we have to use this fiber over this area, because when we put the composite in the deepest area of this cavity, the stress that will be caused by shrinkage of polymerization stress could pull out the composite from the hybrid layer. So curing a piece of fiber, of polymer fiber, of polyethylene fiber over this deepest area will prevent the composite to be pulled from the hybrid layer. And even if the composite is still shrinking, it will shrink over the fiber, not over the hybrid layer. The next step is bond first to enamel. Bond first to enamel, simplify your cavity. And look at this. I don't have any composite over this deepest area. How long time do I take to get in this stage? Maybe like 20 to 30 minutes. That's sufficient time to do the decouple. So, do we have to wait for decouple? For performing like decouple time? Like waiting the 5 minutes? We could do that, okay? But we could stay working after the curing the adhesive by mounting the matrix, by cutting the fiber, by embedding the fiber, by putting the composite to simplify the cavity and bonding first to enamel. And we could perform all the restorative process not linked to doing specifically the decouple, but the decouple will occur just naturally during the restorative process, because it takes time to perform, like to simplify the cavity. It takes time to cut the fiber. It takes time to embed it in pure adhesive. So the decouple will happen. And by the decouple, all the adhesive layer will get mature, and the results of bond strength will get higher, and it will prevent the C factor acting in those deepest areas in this cavity. So I've heard from many teachers, many lectures, don't use the bulk fill restorations. Okay, I agree, don't bulk fill, but if you have in your hand a composite that could be layered horizontally, millimeter by millimeter, you could perform it with like this book flow composite, like I show you here in this case. I didn't fill, as you see in this restoration, all this cavity at once, like book filling, but I used a bulk flow composite to do the horizontal layering. So I construct millimeter by millimeter with flowable composite, and the one I like most is the book flow D from Shofu, that actually has a nice translucence looking like an old and mineralized dentin. And also it has a great translucency that could allow the light to pass more and to convert more monomer to polymer during the polymerization. And also the book flow composite has the capacity to spread softly and to fill all the deepest area without bubble, without gaps. That's the way I restore is bonding first to animal. After that, some book flow as dentin, and then after a enamel of geopacity system. That's another thing during the restoration. What the composite do I had to use? And how do you do, Gustavo, to get this kind of results? Look, I use two kinds of composite. Two kinds of composite. One, one enamel, one enamel of system that is prepared by two opacities, and also one book flow for dentin. By this way, I'm showing you that I could have a natural looking restoration with a simplified layering, but with a very natural looking result. But the best of it is looking in this follow-up. This is already 6 months follow-up, and I could see clearly that also the activity that we has in the first X-ray exam, actually we don't have it anymore in the follow-up X-ray. That's the why the sentence that was said by Mr. Fusayama, if you can seal, it could heal. I seal the dentin, I protect the pulp, I protect the pulp. So I gave the chance for this system to repair itself, to form the tertiary dentin and protect not just the vitality, but protect also the periapex area and the vitality and the healthy of this tooth with a good looking restoration using two composite. I know there is another ways to restore. You could do a polychromatic, you could do B3 pentalaminar restorations, but don't you agree with me? If we are performing a restoration and the last layer that we will put over the tooth has more than 1.5 millimeters, if I'm using like a body shade or maybe a enamel from system of two opacities, the opacity of the composite that is under this enamel isn't too important than the last layer. So that's the why I indicate you strongly choose like body shades or enamel from system of two opacities, like Z2 2500, like Herculite presses, like Harmonized, like Beautiful LS, or like another system that are separated by dentin and enamel. If you are using systems of three opacities, focus on using body shades. Using this strategy of restoration, it will get simple, but not less natural. The naturality of restoration is achieved by the shape. And to know the shape, you have to train a lot. You could do the training by several ways. You could like take a phantom, prepare a phantom, and train your restoration. You could do that at over a Gibson model, for example. Put some composite in that. Take some good books of anatomy, of morphology, like the one from Viktor Sherbakov. It's a spectacular book of seven pages, just it, of pure morphology. You may know him well. Viktor Sherbakov is a Russian guy. I had the chance to stay with him and this last month, and it was incredible course. And he used the StatX from Dentsply that has body shades, and for perform those beautiful restoration, natural, good looking restoration that he's performed. He just used body shades for the body of the restoration, and over the lobes maybe some white for getting more natural, but the body of restoration is constructed using a body shades. So take note. Lesson 1 of direct restoration: simplify using a enamel, once again, of systems of 2 opacities, or body of systems of 3 opacities. Okay? So, our problem, or the major problem doing the restorations on posterior tooth, isn't the shape, right? Okay, you could have a very good looking restorative procedure, but if it isn't well adapted, you have a problem. The first thing that you have to know is, if you perform a very good looking restoration, as this last one that I showed you, with some staining, with all the lobes, with all the good looking characteristics, or if you perform like a fingerprint restoration, but with the volume controlled, both will survive the same thing. For sure, we want to have, we want to get the best good looking restoration, but that's not the important item during the restoration. The important item is to construct a complex that relate hard tissues and soft tissues. And we have to know well all those areas. We have to know well all those areas. First of all, knowing the relation by the proximal ridge height and the top of contactor area. The difference of those 2 heights will perform a obliqual surface, not a straight surface. You know, when the two get together one to another, and for example, in this picture, when you have those 2 premolars, the contact area is above the crystal area, the crystal proximal area. And the difference of those 2 heights, it has to be performed with a obliqual curve. We could do that using, we could perform that using a sectional matrix, but we'll have to establish the proximal area, construct the top part of it, and also positionate the bottom part of contact area, because it's related to the proximal crestal bone area, and the relation of those two heights will allow or not to get the papilla formation. That's a classic paper from Denis Tarnot that was written on 1992, that says to us and show to us, when we have less than 5 millimeters of difference of height from the crestal bone area, crestal proximal bone area, from the bottom of proximal contact area, when we have less than 5 millimeters, we will have the papilla formation. But when we have more than that area or more than that height, the papilla formation wouldn't happen. That's the why we have to understand when to indicate direct, or when we have to indicate indirect or semi-direct restoration, for example. In this specific case, for sure, that's a phantom, but that illustrates very good, in a very good way, what we have to show for our patients. For example, patient, take a look. For you, I couldn't close this black space. I couldn't close this area because it's impossible with direct composite or with direct restoration. I could just perform that approximating the bottom of contact area from the crestal bone, from the proximal crestal bone, doing a preparation. For example, I will prepare this tube for indirect or indirect restoration, taking the bottom area closer to the proximal crestal bone. Then the emergency profile will transpond the position of contact area that's a little bit over it to a position under. So approximate this distance, I could presume for my patient that he will have this problem or this kind of problem solutioned. So that's the why I indicate sometimes indirect restoration or semi-direct restoration, because I couldn't achieve a nice profile emergency. But how to perform a nice profile emergency? When you want to construct a restoration, you have to know that not just the gingival embrasure, but the occlusal embrasure are very important. The buccal embrasures are a little bit more shorter and has a little bit smaller volume than has the palatal or the lingual surfaces of embrasures. Why that? The mid part of those two embrasures, the buccal one and the palatal one, on the middle of it, we have the direction of the principal sulcus or the protrusion sulcus or protrusion groove. Knowing that if I'm constructing, like in this cavity, imagine with me, I have a big cavity like this that I draw here. I have a big cavity. And maybe I take my wedge and put it like this, just like this. What am I doing? I'm opening the buccal embrasure and I'm opening the buccal embrasure and I'm closing the palatal embrasure. Like this, I'm putting the contact area in the wrong place. What it will cause? Maybe it will cause a little movement of this tooth, a mesialization or maybe a distalization, and it will occur. So the stabilization of contact area may be efficient. How to construct a contact area efficiently? The basic setup. You maybe have a ring. I don't know what the system do you use, but every time I will construct a proximal area, I used to use sectional matrix to what? To be put it on the cavity and turn the possibility to restore this proximal area. What do I use? I use polydentia system. That's the classic one that has a delta tubes, and those delta tubes could turn 3/6 all around, and I could place in several ways. If I have a embrasures that are too open, I could use the tiny part of it, and maybe if I have some cospolus, I could use the lateral side of this delta tube, or maybe I could use with any of these delta tubes and position it like in the proximal area. Will promote the separation of tooth and will prevent you to finish with those contact area open. The another system that I use is this one. It's my QuickMat 40. That's really strong rings that separate very strongly the tooth, and it will prevent you to finish the restoration with the contact area opened. The possibility of doing that, working and changing those terminals, you see this system give you the chance to change those terminals for shorter crowns or for cospal loose terminals. And you could use, like in the buccal area, a standard terminal, and in the palatal or lingual area, another terminal, and you could use in several ways. Also, the wedge of the system could pass under this ring and will turn the procedure a little bit more easy to perform. That's my clip 2.0. That's very nice because I don't have to have a palmer to positionate the ring in the tooth. I just have to press, and this ring is very strong, and it separates the tooth also strongly, and it will turn the procedure a little bit more faster with a little bit less instruments to perform those construction of proximal area. And once again, we want to prevent this C factor, but how to prevent the C factor using time? Do I have to do the decouple? Do I have to just wait for the decouple happening? When I have look at this case on the diagnosis and when doing the treatment plan. Sorry, just just a second here. Okay, I'll start again. Okay. Okay, so look at this case. At the diagnosis and the treatment plan of these patients, we indicated one indirect restoration and one direct restoration. Okay? Sorry, two direct restoration. So we prepared those two. Look at the quality of the preparation. We have to see this clean surface that's just possible with magnification with air abrasion. That's impossible to achieve this quality of surface with any of those that I told you, magnification and air abrasion. That's not possible. That's not possible. Caused by those, I could see more and I could prepare better in a deepest area. And that's very important to bond over a clean surface, not just because it's cleaned, but because you are achieving the best condition of tissue to achieve the higher values of bond strength. Look at this second, maybe it's a third molar, but look at this peripheral, these peripheral seals on. What does we have in this area? Look at this. We have the enamel. We have the dentin enamel junction. And we have the peripheral dentin. By controlling this, cleaning and preparing well, we will seal the best way this cavity with the best results of the bond strength that we could perform. But when I see these kind of cavities that with the rubber dam isolation, I could look directly to the most gingival areas. That's indicates me that I have to put adhesive and to cure this adhesive or to polymerizate this adhesive at this time. Why that? Because I don't have the matrix that will cause some shadow in the light. I could clean well all those gingival, all those deepest areas. And when I apply the adhesive and cure it, after that, I have to stay doing the process of the restoration. What the next step after curing the adhesive is putting nothing over the dentin, is mounting the proximal area. So to achieve this picture and to get at this this stage, it takes time. The time to the decouple, and I don't have just wait the decouple happen. I could using my time after curing the adhesive to construct the proximal area. And again, it takes time, and the times do the decouple, and the decouple do the higher bond strand in the dentin, and the higher bond strand in the dentin prevent the C factor or the problems that the C factor cause into those deepest area of this dentin. Look of this enamel that I applied at this proximal area. Look the light reflection over it. The light reflection is just in the middle of it. And as you see, this instrument that I'm using that's called Applica Twist from LM Art. That's an amazing instrument that has 3 kind of angulation and allow me to construct this proximal area with no problem, make this natural, good-looking proximal area, putting the crystal more to the center of the tooth and putting the top part of contact area into the contact of sectional matrices. By this way, simplifying this cavity, as you see here, after constructing the proximal area, I used, as I told you in the beginning of this class, a book flow composite for filling those great part of this restoration. I did that millimeter by millimeter. I used the one from Shofu, the book flow D from Shofu, and now I have the condition simplified to do the restoration. The time that I took to do and to simplify the cavity, turning the class 2 restoration into a class 1 restoration, allowed me to have a very high bond strength result into the dentin and allowed me to use this kind of composite layering millimeter by millimeter. So what did I use for perform this restoration? I used one system of 2 opacities, a enamel shade, and one book flow for dentin. The book flow that I put it in this cavity are 1.5 millimeters from the cavo superficial area. After doing that, this second molar, was for indirect. So after that, in this second molar, I did the finish and polishing, and I took an impression for the restoration. But in those 2 directs, what I did, I take all the mass of this enamel shade, put it over the tooth, controlled all the volume, and the volume is easily controlled when we have a lot of information to perform this restoration. For example, in this case, what do I have? I have the first stage or first stage of occlusion that culminate with longitudinal line that are the point of the cusps. I have also the information of second level of occlusion that are the crestal area. When I just have those two information, that just sufficient to put the instrument over those two structure and with the reference of those two structure to remove the excess, pressing the composite through the cable superficial angle with the reference of those two levels of occlusion. That's described by Paulo Cano, the fourth level of occlusion. The top of cusps, the crestal bone areas, the ridges, and also the grooves. That's the fourth one. So what do we have now? We have also the third area, that are the ridges, as reference, as we could see here. So what lasts the fourth level? Could you see already the design of restoration here? I just take a look at this picture many times. I just could, for me, it looks like it's already has the all the circles, grooves, and all the information that I could achieve in this morphology. But when we are restoring a posterior tooth, we have to know very well the direction of working movements. For example, for lower jaw, what do we have? We have the working side movement. We have the non-working side movement. We have the protrusion movement, and we have the retrusion movement. By this, it's easily way to know that I already have a lot of information to perform. Let's do that in black. To perform or to achieve a natural, good looking morphology of the tooth. Look how many information I do have here, not just to perform a natural good looking restoration, but to perform a long lasting restoration. If I finish the restoration like this, with no sulcus, with no tints, with no nothing, just cure it and finish it, it would last the same time as if I perform like this morphology. But in this manner, the patient could look into restoration and says me, hey, Gustavo, that's incredible. That looks like my tooth again. But the most important thing isn't the natural good looking, but the natural adjusted good looking restoration. When we took off the rubber dam, that's the moment of tension. That's the moment when we going to have the proof if it well constructed, and we doesn't have to take all the morphology that we performed. But that could be preventing knowing those 4 levels of occlusion that I told you before. So what the steps to do that? What the steps to perform those restoration? Look at this. That's the daily dentistry. Daily dentistry. The first thing that we have to treat in this patient, the health of him. Show him how to floss, showing him how to brush, showing him how to prevent this happening again. Because if I perform my restoration in the best way that I could, I did the preparation, I construct the bevel on the cable superficial, I did the air abrasion, I clean everything up, I'm working with rubber dam isolation, but if the patient isn't treated with the acknowledgement that he has to take care himself of his tooth by brushing, by flossing, the restoration wouldn't last. Because remember what Jack Furcan showed us, the high risk status patients still the high risk patient, even if he has adamantium as a restorative material. I'm just kidding, for sure. Adamantium is just for Wolverine, but we were starting with composite, and we may take care not just the composite but the health of these patients. We are reconnecting things, okay, but we have to reconnect in the meaning of the patients to know that he has to control himself the long lasting of this restoration. All of our work we are performing by rubber dam, by preparing, by cleaning, by mounting the matrix system. And in this case specifically, look at this. I have not one but three cavities, three proximal cavities, and I'm doing that at once. But what am I using here? I'm using two systems, the classic one from Prudentia and also the 40 one. Not just that, I'm using also these matrices that are incredible, that the QuickMat Flex, that's a flexible matrix with nickel titanium ligature of material that allows this metal to doesn't fold permanently. That make the possibility to fold a little bit and to return into the initial shape. And that's very, very thin. It has 0.2 millimeters of thickness, and these thicknesses allows me to construct those proximal areas together. What the first step in this case that I have to mount all the stuffs, all those matrices and bands and wedges and rings before applying the adhesive. I have to mount it, check the deepest area if the matrix is well adapted, using wedges like this. That's plastic wedges. In this case, I put some Teflon in those areas to close a little bit more this embrasure, because remember, the lingual and palatal embrasure are a little bit more open than the buccal one that's a little bit closer. And so this first stage is to have a look in, is to take a picture, is to evaluate the relation of the embrasures, is to evaluate the relation of the matrix to the deepest areas of the cavity. After that, I will apply the adhesive. So if am I applying the adhesive when I before it mounted all those stuffs, those metal bands, rings, these wedges or whatever, I had to take care to remove all the excess of adhesive in the deepest areas of this cavity. So for do that, I just have to take like endodontic suction system, or maybe a surgery suction system, and remove the excess from the deepest area and evaporate all the solvents that are in those adhesive system that you are using. I'm not here to talk about adhesive system, but there is no way to talk about restorative and don't have any tip about how to prevent this problem that those adhesive system could cause during the restorative procedures. So what I did was apply the adhesive, and now I transform from a very hard way to restore with a lot of class 2 cavities, and I simplify into class 1 cavities. But first, I'll get back here. Look, first of bonding to the dentin, I'm bonding to the enamel. Look at here, I'm just bonding into enamel. Once again, I'm just bonding into enamel, and look at the light reflection. The light reflection is just in the center of this proximal area that I construct. From the center to the matrix, to the metal matrix, I have a obliqual surface, because by this way I prevent to construct two straight contact area. And look that after the construction, what do I have to do to finish this proximal area? Nothing. The best polished composite that I could achieve is the composite that is polymerizated into or corner the matrix band. If I don't have to touch this area, I will achieve a very polished surface in this proximal area. That's sufficient for the construction, and that will allow me to be more accurate during the construction, not just by simplifying the cavity, but simplifying the finishing and polishing of this restoration. Look at the mesial of this first molar. Once again, the light reflection in the position of the second level of occlusion. Once again, the light reflection in the second level of occlusion. Once again, the light reflection in the second level of occlusion. That's very important thing during direct restoration. You have to take a look, you have to take pictures. That's the wide importance of take pictures. The picture don't lie to you. If it's okay, it's okay. If it's not, it's not. You have to correct. If you construct this area too high, you could repair it before following the restoration. I didn't have to do that in this case, but if I had, I could take some diamond disc, I could take some burrs, I could take some instrument to reduce the area that I construct too high, and then just follow the restoration, just re-wetting the composite that I touch with the bars or with the discs. You could do that with a modeling, composite, compomer. I don't know. What do you use? I use the one from Bisco, the modeling resin. I use also the one from Ultradent, the composite wetting. But there is a lot of brands of this kind of material. Or you could use like a pure bond adhesive in the systems of the 3 steps, like OptiBond FL, for example. After that, as you see, I just work like this system, one enamel of 2 opacities. This one that I'm using in this case is the one from Care, the Harmonize for enamel shade A2, and a book flow for the dentin. After that, you could see, after the finishing and polishing, how natural good looking is this restoration. And you could see here, after 1 year, it's just performing very well. Do I have to touch again? Do we have to repolish this restoration again? No, we don't have to do nothing. You just have to touch the composite if it's truly stained, or if it has, say, don't know, maybe a little bubble or maybe a little crack, then you could repair it. But if you have just a little bit of staining, just a little bit of bubble, don't touch that. By touching the composite, you will turn the lifetime of this composite a little bit lower than that could perform. But what's important of all? The important, once again, is to providing health. Health. This patient, a very young patient that I had to restore, 18 years old girl, the first thing of all, teaching her how to floss, how to brush. Afterwards, I could perform the best of mine. Because I could perform the best of mine in this world that this patient is not taking care a lot. And what I'm going to see a failing restoration. I'm going to see a failing restoration in a very short time, in a very short period of time. Even if I perform the best of mine, the patient don't brush, the patient don't floss, she will have problem. So she has to have the conscience of cleaning and the health of it. But also the construction has to provide health for the patient. So to prepare the tooth, use all the tools that you have in your hand. I'm using here the piezosonic tips. That's the one from CV Dentist. That's a Brazilian piezosonic tips. That's an amazing system. I'm also using a manual excavator. That's the one from LM in the second picture. And look at this. I have to take care to prepare all this peripheral zone area and preventing the pulpal exposure. And whenever I could apply the adhesive, I could apply the resin coating before the construction, I'll do that. And at this case, what I did, I used some Teflon to do some retraction in those gingival areas and allow me to apply that adhesive, not just to apply, but to remove the excess and to cure it well, to polymerizate it well. The first step of those restoration, when we have some mesial cavities like in this first molar and the second premolar, I have to turn it into a closed cavity like this. I close those cavities before perform the class 2 cavities. What did I use for restart this cavity? I will use, and you've seen that I already put some flowable composite over the adhesive. So what I perform? I performed the IDS and also the resin coating before the restoration and before simplifying the cavities. But take a deeper look into this first molar. How many information does we have? Also into the second and the first premolar. Do we have here the first level of occlusion? I'll write here, level of occlusion. The first level of occlusion. First level of occlusion. First level of occlusion. Once again, first level of occlusion. Once again, first level of occlusion. Whoa, that's a lot of information for me. What does we have? Second level of occlusion. Here, a little piece, but still a second level of occlusion. Second level of occlusion. Second level of occlusion. And we also had the third level of occlusion. Third level of occlusion. Third level of occlusion. How many information does we have here? It looks like a big restoration, but actually it's not. It's just a complicated to restart. Yes, it is, but it's full of information. It's easily to restore. Another information that I could achieve during the process here is the fourth level of occlusion. Here we have fourth level of occlusion showing us where to go. Where do I have to go here? Well, I have to go from central fossil to proximal area, connecting it. Like this. The protrusion groove. Also the protrusion groove. And that's it. From the central pit to the protrusion groove to the retrusion from non-working groove. That's in that way I could perform restoration knowing where am I at. So I just close those proximal spaces and I also perform this first molar restoration. Look at this again. Central pit, working groove, protrusion groove, proximal delta. Distal pit, non-working groove, non-working lateral protrusion groove. By this, I know where I'm going to get. And after that, I mounted the matrix system. I used two I used two rings of the same system. This system is the QuickMat 40 from Polidentia, and it's really strong. 40 in Italian is, or also in Portuguese, also in Spanish, is strong. And this ring is very strong to do the separation and to prevent a open contact area. But what do we have to look when we are constructing concomitant cavities like this. We have to, first of all, prevent the space that are occupied by the matrix using a very strong ring to do the separation. Okay, first step is this. If we are performing concomitant cavities, I have to know that the most mesial cavity, like this first premolar, had to be mounted before the second one, that is the second premolar. As you see, the ring, that this purple or this pink ring, is under the blue one. This pink terminal, this pink ring, is a ring for the shorter crown, and the blue one is for standard size. So I put them together, and then I simplified the cavity. Once again, look at the light reflection that's obviously here. What do you have here? Second level of occlusion. Now, with all this information, with this cavity very simplified, I could just take a first look of it and know that I will have no problem or no work to polish this proximal area. That's amazing. That's amazing part of constructing direct restoration. Remember all the things that we start to think before performing the restoration. We made a scanning of the area by finding the levels of occlusion to perform the design of the morphology, guided by the cuspal ridge inclination and also by the levels of occlusion. So what I did, from the central pit, I designed the working groove. From the central pit, the protrusion groove. And as I had this area well marked, I performed a delta, proximal delta, with a well pronouncement. Afterwards, I designed from the distal pit, the non-working groove into this proximal area and the animal ridge in this first molar. And for those two premolars, what do I have of information? Look here. I have everything showing me how to perform the design of the restoration. What the next step? The next step is flowable composite on the deepest area. Animal shade, I use here harmonize from care, harmonize, animal A2A, enamel A2. Just those two composite. For posterior tooth, it's very, very simple. You have to have a A2 and a A3, and you will solutionate like 85% of your cases. You don't have to have a lot of composites. Like with 5 or 6, not more than that, you could solutionate or could restore 100% of your cases with very natural, good-looking restorations. So that's what I did. I put the restoration, removed all the cess, controlled the volume, controlled the inclination of all those faces and surfaces, and then after that, apply the tints, polymerizate that well, and that enter very important points for restoration. Your light system has to have 4 important points to achieve the best quality, not just of composite, but also for the hybrid layer. The light has to have a very good collimation. with a very nice irradiance, that is the power divided by the area. Whenever you have deeper cavities like this, you have to extend the time understanding the material opacity. And that's the why I like the flowable, the book flow composite from shop food that I told you. The translucence of this material is very low, and it allows, with not so extended time, to cure well, to polymerizate well the composite during the material opacity. The one I use is the one from Ultradent, the Velo. That's the best, for sure, the best light system in the world by this time. I don't know, maybe in the next year, but by this time, this is the best in the world. And not just about those 4 points, but the main point, that is the ergonomy. The ergonomy that is provided by this light system. When I'm polishing composite, every time that I'm polishing composite, I don't use water for polishing, because use water I couldn't see whenever it got polished. The first time I heard that was from Tony Rotondo. Whenever you're polishing, you have to see, you have to take a look. And if you're doing that with water, you're not allowed to see whenever it polished. You could causing some tension over the surface, and those tension could accelerate the failure of the restoration. So to prevent also the tension that the finishing system could cause into the restoration, low speed, very low speed, lower than 6,000 RPM. In this case, I use two steps, two-step system, this Canda Noblis, and the first one with 6,000 RPM, the second one with 4,000 RPM. Because the composite, it's a plastic. It's full of plastic. Plastic doesn't allow you to use high speed. You have to have low speed. You could use water to clean a little bit, but you will just see whenever it polish with the water. The last step that I use for finishing like this is using an carbide silicone brush. Carbide silicone brush. And that one with very low speed, 3,000 RPM, not more than that. The one that I use is the one from DH Pro. It's a Brazilian enterprise, but another one that I use also that you could found easily is the one from Ultradent, the Jiffy brush. It's a very nice brush. It's a little bit more harder than the DH Pro that I use, but you could make it softer just before putting it into restoration into a tube. Take some composite in your office, cure it, and make it, make it like a square or a ball, and just use this carbide silicone a little bit in this composite outside of the mouth before using it over a tooth or over a restoration. And whenever I have a lot of information, the adjustments is just to a little and a few adjustments and I don't have to be worried because I have a lot of information like this. I have the first level of occlusion, the second level of occlusion that guided me to construct a restoration with no adjustments. There are a lot of ways to achieve this kind of result. This one was a quite easy restoration, but because it has a lot of information, but I could have this kind of result also with a big restoration, and I will show you afterwards. That's another side of the same patient, the same protocol, rubber dam, remove all the restoration, IDS, resin coating, I restore this proximal area, I mountain the system, and that's the tip. I used two matrices from another system from Garrison that is thinner than the system that I use from Polydentia. The system that I use from Polydentia, the Lumini contrast has 0.4 of thickness, and this one from Garrison has, let's do that in white, has 0.2 millimeters. That's just the middle. That's the why I use 2. That's the why I perform this restoration like this, and the step by step is the same, and all the references are the same. Once again, note the light reflection in the proximal ridges area. So I transform that into a class 1 cavity, then I restore, finish, and polish, adjusted. There was no adjustment. I also performed the same protocol, the very same protocol, the restoration of those second molar, and look here, how good looking are those restoration after 2 years, how healthy are those restoration after 2 years, that's surviving very well. Patients is feeling nothing and doing well, cleaning well, and that made me happy to see this kind of result. And I swear for my sons, I didn't touch this composite to take this picture. Another way and another problem is whenever you have to construct some proximal areas and you don't have, or maybe you have the doubt from where this cavity will stop. For example, I was afraid in this cavity that I was ending the preparation with this proximal area opened during the cracks that I saw here. What I did, I custom the ring using the classic system one from Polydentia. How is the protocol for custom rings? First step, you have to isolate the tooth. So I used some glycerin to isolate the tooth. Second step, positionate the wedge. Third step, I positionate this composite, that's a custom composite, also from Polydentia. Then I cured that. Third step, I positioned the ring. Fourth step, I filled with this custom composite. Then what I have a custom ring. For what? For custom embrasure. So in the second day, because I performed those two restorations in the first and the second molar, then in the second day, the patient got back and I removed all this old restoration. I did the aeration, cleaned it well, prepared it well. I restored this very tiny cavity in this proximal area. Then I simplified the restoration. Look, I applied the adhesive and I polymerized this adhesive first before the proximal constructing area, or for before mounting this matrices system. By that, and taking the time, the decouple will happen, the bond strengthening and denting will get higher, and the C factor problems caused by the polymerization or the shrinkage of the composite will be less problem in this direct restoration. And also, I construct these proximal boxes without bonding to the dentin, preventing also tension caused by the shrinkage over this deepest area of dentin. Then, after that, flowable, book flowable composite, and this system is the one that I most like, is Herculite presses from Care, also kindly called by me Herculite Petris. I really love this composite. It's a very it's not so low viscosity composite, it's a high viscosity composite. What I most like, because I like to do horizontal restoration and design over this composite after the first settlement of the composite. That's what was before, and that was after the restoration. That was the before situation, that was right after result, and that's also 1.8 years of follow-up. As you see, I was very afraid to before doing those restoration in the first and the second molar, that I was going to remove the proximal boxes during the cracks that I saw. But what I did was reduce the cracks inside the cavity during the preparation through the animal dentin animal junction, remove or reducing the cracks into those areas, because the cracks are the biggest problem caused by those metallic restoration, as you see in this one. First step, isolate everything. Take a look, not just for occlusal, but from buccal, but from most mesial part, and evaluate if what you are going to do. For example, I have this crack here, and I also has this crack here. Vertical cracks and horizontal cracks are the same? No, they're not the same. Vertical cracks like this one, I'm not afraid of. But horizontal cracks, and also in the distal mesial side to side, is a thing that I have to worry about. If I have some cracks in those areas, I will have to reduce. In this case, I reduce not the whole cusp, because I really don't believe that reducing cusp, you will prevent that for never crack again, or for never broke again. You could reduce the crack by doing the preparation through the dentin animal junction. But I don't have to overlay everything to be biomimetic. I don't have to use fiber in everything to be biomimetic. I have to know the protocol to restore, and the step-by-step to do that, and to bond over a clean surface and very well prepared surface, preventing the pulp exposure, and maintain this tooth alive to be biomimetic. Being biomimetic is maintain pulp alive and reconnecting things. What I did here, I performed a selective etching for a self-etch system. I used here the one from Shofu. It's incredible. FL bond from Shofu that has also bioactivity. As you see, it's a very well applied. There is no excess, and all the system was mounted at the same time. What I just have to care about is the adaptation of the matrix in the deepest area and the most gingival area. After that, simplify the cavity. As you see here, I simplify the cavity, turning it into a class 1, and afterwards, step by step, I construct this restoration. I did the tints, did the polishing, and that's how the restoration looks afterwards. And as you can see in the proximal area of this molar, look at adaptation of the composite. And I swear, once again, I didn't touch this area. This was just constructed by the matrix, just well adapted to this proximal area. And every time you construct a restoration, try to take a look in different angles. Let's get back. Doing that, I evaluate all the inclinations, third inclination, second inclination, and gingival inclination, and also for the occlusal surface inclination following the side tooths. I have to evaluate that, taking a look from the frontal side, from the buccal side, and also for the occlusal size. And also here, as you see, that's 1.5 year of follow-up, and I used no fiber, I did no reduction, and that's surviving well just by a simple restorative procedure with a very well adjusted restoration. And every time that I perform a follow-up, I check the occlusion again, and I check the wear to maybe prevent some fracture in a further time. And if I have to reduce some area, I will reduce until I get softer contact relation through the antagonistic tooth. And what if I have some bigger problem? Oh, imagine some situation like this. This situation is the perfect situation for indirect composite restoration. But there is any difference of surviving rate comparing direct to the indirect restoration? No, there is no difference. The difference is over the longevity of the restoration are the objective or the goal of the dentist. So who has to be prepared to perform or an indirect or direct restoration in whatever kind of cavity it is the dentist. So the survival rate of direct or indirect composite restoration are the same. It depends all the knowledge of the dentist, the tools that he has, and if he knows very well the procedure and how to perform that, if he has to perform this directly. In this case, I had to perform this directly because I was in another city and this patient has just this day to restore, and I didn't have time to perform an indirect restoration. So what I did was working with some guides, that is actually some tools to perform restoration. But take a look of this crazy cavity. Take a look of those bigger cracks that I have. If I want to chase this crack and to remove this crack to the end point, as my mentor Pascal, as my mentor Dave Dalman teach me, I will get into the poop. So in this case, I just stopped here. I just thought, no, I can't go further. I can't go further. So by at this time, I have now to prevent the tension of the residual tension that the mastication and also the occlusion of the patient transfer to the tooth. So what I did here, I had to do a direct restoration. So the first step, applying the adhesive. So I did selective etching, but pay attention here. I do have here etching into the dentin. So if I'm touching the dentin with phosphoric acid gel, I have to concern of using self-etch system. What did I did? I used a multi-mode as a primer. Why that? Because I have etched this dentin, I have touched this dentin that is compounded by the dentin enamel junction. And if I touch this dentin and remove this smear layer, the self-etch system don't interactive in the proper way again. So that's the why I use the multi-mode as a primer. So I apply the multi-mode. I used here Albond U. Let's do that in white. Albond U from Bisco. I applied 2 layers of Albond U. So I applied, I removed excess, I volatilized, I removed all the solvents in it. Then I repeated the process. Then I don't cure. And I applied the OptiBond FL, just the bond, just adhesive, as I would be using like a 3-step technique for self-etch or for etch and rinse systems. I really don't believe that I strongly believe and I strongly recommend you to don't use just simplified systems by itself. Try to integrate simplified system as any multimode that you use with another bond system and put them together. Van Meerbeek in 2013. Van Meerbeek. I don't know if I'm writing if I'm writing right his name, but you will find his paper. He tested a lot of combinations of primer from one system to the bonding of another system, a multimodal of one system with bond of another system. And also there is another researcher here from Brazil, Marcelo Giannini, and all his group of researchers that performed a lot of research using this kind of approach, using a multimode as a primer. And all the multimode and all the simplified system has a problem that deliver us a very thin hybrid layer, which is a problem because it's too hydrophilic, and the hydrolyzation will occur in a very shorter time than comparing to a system that deliver a thicker layer of hybrid layer with the bonding system. So that's the why I use this kind of approach, because as you see, the selective etching is not just so selective. I touch indenting in some areas. That's the why I use the multimode as a primer, because the multimode as a primer, it could be applied as self-etch where the phosphoric acid didn't touch, and in the area that the phosphoric acid touch and remove this mirror layer, it will act as a etch and rinse system. But the problem that there is in those systems, simplified system, is removed using this extra bond layer, like I did in this case. And the next step of it is prevent the tension in those deepest area or over those cracks that I have here. That's the why I use these polyethylene fibers over the cracks. It's enhancing also for sure the hybrid layer, but the best thing of polyethylene fiber is that it simulates a new dentin enamel junction. The function of dentin enamel junction is to take all the vertical tension and transform it into a horizontal tension. That's what am I doing here. I'm using the fiber not to reinforce the tooth, but to transform the tension that will get into this deepest area during the function and transform it into horizontal tension, and maybe preventing some new fracture. The second step after putting this fiber is to use the resin coating and transform this restoration into a transform this complicated cavity into a simplified cavity. I'm using here the system of Garrison. I'm using no rings because I didn't have the buccal surface to mount the system. That's the why I just using the matrices, the metallic matrices, and also the wedges. So what I did was perform the construction of this area because I didn't have to close the contact. I already had the contact area. So that's the why I construct this. I close this this wall first. Then I remove this matrix and also the wedge. Then, so I did that first. Then I construct this in green in the second step. Then I remove the third step. I remove the third step. I remove this matrix. Then I turn it to another side, and then I construct the proximal area of the second molar. That's the fourth step. By that way, I have a little bit more simplified cavity, but I still has the buccal side to construct. That's the why I use some silicon index that I copy the tooth before the preparation. But how did I prevent the cracks that I already have in the buccal side of this second molar that I had? I take some composite and with no adhesion into the tooth, I did some direct mock-up to the buccal cusps of the second molars, and I did cutted the excess to allow this matrix achieve the right position. And I always make the conference the matrices into the cavity and the reference that I have on the intact tooth to prevent the misposition of this matrix. Then I construct, and then I'm achieving again the first level of occlusion. Look how great is here. Now I have the second level of occlusion. I'll put it in red. Second level of occlusion, second level of occlusion, and the first level of occlusion. And now I have a simplified cavity, but it's still a big cavity to construct. What I did use a direct occlusal index. I call this like this. This case was a very big case, and I was restoring the whole mouth, and I have these printed models. I cut those pieces. I did all the sides, all the restoration. The tooth of this woman, poor of this woman, was in my hand like for 3 days with non-stop restorative procedures. But at the end, she's still healthy, and I'm still happy. But I use this index, this occlusal index, to position it after the applying of this occlusal volume of composite. I remember the first steps. I remove all the old restoration, prepared it well, cleaned it well, applied the adhesive, turned the class 2 into a class 1, chasing for the levels of occlusion. So I restored the first, second level of occlusion, and then now I'm chasing the fourth and the third level of occlusion. So I use the direct occlusal index, stamping this composite before removing the excess. But take a deeper look. What I got here, I got all the information that I have to restore it again. All those signs that I got from the occlusal of direct occlusal index provides me the way to restore, because I know the interaction of the antagonist through this tooth that I'm restoring. I know that the working cusp of the lower jaw that is touching this central area, shows me the central pit. And I know that the work movement goes through the buccal side from the central pit. So I have the working groove. Okay, well, I know that from the central pit to the mesial side, I has the protrusion movement. So I has here the protrusion groove. And I also know that from the central pit and the distal pit, I have the retrusion movement. So I have the retrusion movement a little bit here, but I have the animal ridge in this central ridge in this first molar, and in the second molar I don't have this, so I have the retrusion groove in here. And from non-working groove, from non-working movement, and from the distal pit, I have the non-working groove. So that's finished. That's all I have to know to design this restoration again. I used here Z2500 3M, the XT1. That's incredible. That just one composite and a very natural, good looking restoration. That's what I want to achieve. Not just that, but a very healthy restoration. But sometimes I really have to push myself, struggle me to restore some cases like this. That's a very kind uncle of mine and a very old uncle of mine. For sure, this patient has to go for a total rehab, but she is 90 years old, my friends. 90 years old. And look at this. It looks great for a 90 years old woman. Yeah, there is a lot of wear. There is this pose. I don't know what is this doing there, but at this time I knew that I would have to go into a direct restoration because I don't have the time for doing more than 2 to 3 appointments with this patient, and this patient would like and ask me if I could do that directly. And as I said you, if I have the tools, I could perform it directly. I just have to follow the protocols, and I have to follow the step by step to perform the restoration like this. First step is isolate before applying the system, the adhesive system. The second step is simplify whatever you could simplify. So I simplify this cavity of the second premolar, transforming it from a very complicated cavity into a simplified cavity. And once again, the light reflection, as you see in the second level of occlusion, and I'd have no composite into this deepest area of dentin. Then I simplified everything. I controlled freehandly this distal side, flowable composite, flowable flow composite into the deepest area, and then a body shade. I use a body shade here, body shade A3 Forma Ultradent. Here in Brazil, it's a very cheap composite. It costs like 100 reais. So it's very cheap. And I like too much because it's a very hard composite. And as I said, I love to work with composites that are more firm and not with low viscosity. Okay, so I finished the second molar. I make the finish and polishing of the distal side of the second molar, and then I started to construct the second molar. First of all, I could use any system of ring here for sure, but what I did was to positionate the composite in this area, for just making a little bit deep margin relocation, and to positionate the true contact point area into the area that I want to put this this contact. So I cured a little ball of composite and I pressed it into this mass that I put freehandly with just this sectional matrix with no ring system for doing the separation of this two. I also use this wedge to helping me and achieve a nice contact area. And for occlusal construct, I took impression after the isolation with alginating, and I pour some bisacryl composite, and I have now a direct occlusal index that's sufficient to guide me and construct this restoration. For sure, it's not well finished, but you could see after finishing that it's actually good looking restoration. If you remember, I have this initial condition, that's the mediate condition, and that's 1.5 years of a follow-up. That's what I want, that immediate result, and 1.5 year follow-up of this old lady, and she's still healthy, she's still happy with the stuff. For sure, that's not the beautiful restoration that you saw in your life, like the Vitor Sherbakov, the Malchenko, and Dr. Beretta, and Dr. Newton Fall, and another dentist that are my mentors. But it is still healthy, and that's the why we perform restorations like this. I hope you guys like this class. I have to thank you so much for your time. That's my Instagram. You could tag me, you could send me message. That's my email. You can send me message, and those are my life, my son and my daughter, that I love them too much. Thank you so much. I want to see you soon, and stay tuned. Okay, you could read for the fourth level of occlusion. I'll take it here. Just a minute. Okay, here I have a book that guides me. That book is from Paulo Cano, and it's Challenge the Nature, the title of this book, and it shows me the four level of occlusion and how to restore it. And that challenge of nature was writing using waxing up to teach us how to work, and I could work with composite by the same manner that he is teaching us with this book. Any other question? Is that okay? Heraldo, Leonid, Valeria, did we went great? Okay, awesome. Thank you so much. I'm so sorry if sometimes my English was not the best. I forgot some words. I tried to struggle myself to do the best, but you know, I'm Portuguese speaker, so I try to get my best for the next time. Are we done, guys?